Well, hello, future medical students. So, my name's Javi. I'm part of the team here at Med School Coach. And today we're going to be having this awesome super event called Are You Smarter Than a Doctor? But before we get started, I kind of want to talk really briefly about it. So, the way we're going to be running this show today, the little game show of ours, is we're going to be showcasing this awesome tool called Full Code Medical, which I tried it when I was in med school myself. It's actually super, super good. But the people that are going to, be helping us run this show today, we're gonna have our two physicians from Med School Coach. One of them being Dr. Dan Katz, who is a GI fellow, and then the other one being our founder as well is Dr. Sahil Matel. And then really briefly before they introduce themselves, just want to mention we also have the founder of Full Code Medical here, Michael, and I'll let Michael kind of talk about his story. All right, I'm gonna turn my camera off and leave it to y'all.
We are excited to be here. I wanted to turn the mic over to Mike just for a second to talk a little bit about Full Code Medical and the awesome simulation you guys are about to witness.
Great. Thanks, Sahil, and a pleasure to get the opportunity, everybody, to show you the software that I'm building with my co-founder over at Mass General. The idea is to let everybody practice medicine a lot more frequently than you can today using simulation. Basically, we've turned it into a fun, serious learning game. So it's all about practicing real diagnostic scenarios on a smartphone or in your browser. So you'll get to see that tonight, and I'm excited to watch along and see how the Med School Coach guys do it.
Awesome. We're super excited, and I think everybody's going to be super stoked about the software. It's really cool. It's a full real simulation. And I see a ton of people out there in the chat, which is awesome. You're actually going to learn real medicine today, which is what is super cool about this. The other thing we love is, as Javi said, chat away, because we love to hear things in chat. We're going to be asking questions as we go and try to make this as real as possible. Dr. Katz and I are going to be going back and forth trying to diagnose these patients, and we want you guys to help. And so as we go through each of these simulations, I would love for you guys to be pounding away in the chat, asking questions, coming up with answers and solutions too, because that's what we're here for. So without further ado, why don't we wrap into one of our cases? Dr. Katz, you want to fire him up?
Absolutely. Let's get started with our first case. And just so everyone knows, we're going to be doing this pretty much real time. So when we ask questions, we want to hear answers right away. Be writing in the chat, be talking about what you think might be going on and what the next best steps are going to be. So our first case is a patient who sent in from urgent care via a private vehicle. It's a 29-year-old male sent to the emergency room from urgent care with abdominal pain since yesterday. And the patient has nausea and no fever. So let's get started. What's the first thing you're seeing? What should we be doing? Everyone just write in the chat what kind of next steps we can do even just to get started.
All right, so we got a bunch of people saying, let's do some vitals, let's take a history. I think all these are very reasonable first steps, checking a pulse, that's part of taking vitals, right? So for you guys out there, the vital signs include things like blood pressure, things like pulse, things like oxygen saturation, respiratory rate. So Dr. Katz just turned on our vital machine, and you guys can see actually what the vitals are right there. Can anybody see of those? Well, actually, let's go step by step. Does everybody know what HR stands for? Yeah, exactly. Heart rate. HR is the heart rate. T is the temperature in Celsius. Then we have O2 saturation over there. That's your oxygen saturation, how well your lungs are oxygenating. You have your BP, which is your blood pressure, and you have the respiratory rate, which is 18. So quickly, maybe by the chat, what do you guys think is wrong with any of these vitals? Or any of these incorrect? All right, so I got a lot of heart rate is high. Dr. Katz, what do you think?
Heart rate is definitely high, and normal heart rates anywhere between maybe 60 to 100, and here it's 117. It's in the 1 teens consistently here.
Yeah. Anything else? I see somebody said rapid breathing. So he's breathing at 18 breaths per minute, which is actually high. A normal rate is somewhere between 8 and 12. Normal respiratory rate is between 8 and 12 breaths per minute, so that's definitely high too. We got other couple people who say elevated systolic blood pressure. The blood pressure is actually reasonable, I would say, in a guy like this. This is not totally elevated. And then the temp, it doesn't seem like he has a high fever, maybe slightly higher than normal, but sort of not, he's not super febrile, and he's oxygenating it just fine. So, all right, so we've collected the vitals. Great job, everybody. What's the next thing you guys want to do? All right, talk to the patient. Yeah, I like that. So we're actually gonna talk to the patient. So,
What
Dr.
do we
Katz,
want to ask?
still having
You tell me
conversation
what
here.
to ask, and I'll start writing things.
All right, so what are people asking? So people are asking, hey, where is your pain?
Where is your pain? So the patient says in the middle and on the right side of my stomach, doc.
Okay, they ask, do you have any preconditions?
Let's see, any other conditions? Oh, just feeling nauseous and that, some cold chills. What about medical problems? Okay, no past medical histories or medications.
Sounds like this guy is pretty healthy. I got another couple of questions, lots of questions. You guys are doing great, right? How would you describe your pain? Is it sharp?
Ah, sharp ache in the middle and on the right side of my stomach.
All right, fair enough. Somebody asked about family history as well.
Let's see about family history. Nope.
No family history. Others are asking the last time this person had food or drink.
You ate. Haven't eaten much today and not feeling hungry at all.
All right, it's a good question here. Is there coffee grinds in your vomit?
Ooh, what are we thinking of there? Nope.
Nope, didn't notice anything in my vomit. Dr. Katz,
Yeah,
that's an interesting question. And as a GI doc, you want to give a quick
yeah,
lesson?
GI fellow, that's a question I oftentimes ask because when someone's vomiting something that looks like coffee grounds, you might start to think of maybe there's ongoing bleeding somewhere in the upper intestinal tract, like the esophagus or the stomach. So that's a great question, but this patient didn't notice anything like that.
They also didn't notice any blood in the vomit. That was a good question as well, but I think we may have covered that. Um, all right, so I think we've asked a good bit of questions. Um, Anybody have what you guys want to do next? So, and by the way, we can do a bunch of things, right? We could start stabilizing the patient by starting an IV. We could give medications. We can examine the patient. We could rush them to surgery. We could do a whole bunch of things. So interested to hear what you guys think is the next thing. And I'm getting a lot of abdominal exam, which seems fairly reasonable.
That's a good thing to do. Let's do an abdominal exam. So there's right-sided pain with palpation of the left lower quadrant. There's bowel sounds, and there's right lower quadrant tenderness with mild guarding, no rebound, and the abdomen is soft. So a couple interesting findings there, right? With pain on the right side of the belly when you press on the left side of the belly, and then also just tenderness in that area with some guarding.
Okay, so those are definitely interesting. You can see he's actually grabbing what looks like he was grabbing his left lower quadrant there. But he's certainly grabbing his lower belly. All right, so we did a quick exam. Do you guys want to examine anything else? I mean, we examined the abdomen. Do you think it's reasonable to examine a few other things? Lungs and heart, maybe. I think that's always probably a reasonable exam. Remember, this guy is tachycardic, right? So we probably want to at least listen to his heart, see what's going on there.
Okay, so there's a bilateral symmetric breath sounds with normal chest rise on the lung exam, and the heart exam just shows a fast heart rhythm like we already talked about with a regular rhythm. No murmurs, rubs, or gallops. And then lung exam more so here, clear to auscultation bilaterally.
Somebody asked, and we have some very smart pre-meds in this audience. Somebody asked any CVAT, which stands for costovertebral angle tenderness. So costovertebral tenderness, is there any there, and what would that sort of lead us to?
No CVA tenderness in this patient. That's a good point, right? Because we're looking for things like maybe infections of the kidney or kidney stones or things like that, right?
Yeah, the costovertebral angle. So usually, what you do when you're trying to find this is actually you take a fist and you kind of punch on the guy's back, right where his kidneys would be. And that is a really, if that's positive, that's CVA tenderness. And that's something that's good and, worrisome for some kind of kidney issue, maybe like a stone or a pyelonephritis, which is an infection of the kidney. And actually, he sounds like he doesn't have that. We definitely have some people out there who are also saying things like urine dipstick. I don't know if we can do that in here.
We can start getting things like blood work and additional testing, but before we even get to additional investigation to try to figure out the diagnosis, we are seeing some abnormal things, right? The heart rate's high. The patient did note that they vomited, and so maybe we want to do something first before investigating to just help him. What are our thoughts about those types of interventions we can do?
I got a lot of people saying IV, which is a very reasonable first step. If you get into the hospital, you're usually going to get an IV placed, right? IVs allow us to give medication, draw blood, do all kinds of things that make life a lot easier when you're in the emergency room or in the hospital. I got a couple of people saying fluids and Zofran. Fluids certainly sounds like a good idea.
Which fluid should we give if we're going to give fluids? So there's a few different options here. Anything in particular jumps out at people for what we should give?
So again, we got some solid pre-meds here, or they've watched a lot of medical shows because almost everybody is saying normal saline as a starting point, which I think is very reasonable in this case.
Half a liter or a liter? What should we give?
People are saying bolus, liter, half. We're all over the place in terms of exactly what to give. I don't know, Dr. Katz. What would you give?
Let's give a liter and see how that affects things. So the heart rate's now already coming down to 103, 105, already better than it was before with around 115 before. So an improvement in the heart rate already. We're trying to bring it back to normal. So that was a great intervention for everyone who recommended that. What else? What?
So any other interventions you guys want to start going? And actually, a lot of people have noticed that his BP did go up. Now, remember, his BP before I think was in the 124 over 70 range, and now it's 130 over 70. To me, that's not really all that impressive. It's fine. It went up a little. We give fluids. We would expect it to go up. You expect the intravascular volume to increase because we've given those fluids. And so that much of a blood pressure increase, that's fine. It's still, it's maybe slightly elevated, but it's nothing that we're going to chase with, let's say, a beta blocker or anything like that to bring it down.
Absolutely. So, and as we're doing this, as you're talking, I see the patient keeps grabbing at his belly and looking uncomfortable. So, everyone who is recommending additional interventions, what are some of those things we can do to help right now?
Yeah, we got a lot of people saying pain meds, pain meds.
Right. What can we give for pain? What can we give for pain? We have a lot of different options here. One thing I see on here is a morphine bolus. What are our thoughts about that? Yes, no?
So we got a lot of people with yes and no's. They're sort of all over the place. A lot of people are leaning towards Tylenol, acetaminophen. Other people are saying definitely no morphine. I don't know, Dr. Katz, what would you do in this situation?
No, those are all, there's great options. When somebody presents to the emergency room like this patient and they're in a lot of pain, we want to make sure we address that pain quickly rather than kind of just give things to coat it a little bit. Morphine's commonly used in the emergency room, and it's a really good short-acting pain medication. So I would honestly opt to use it.
I would say that's totally reasonable as well. I mean, this patient in reality has probably been waiting in the waiting room for about 40 minutes before he even got back to the bed. It's probably time to get him a little bit more comfortable, particularly because he's because he's in so much pain. And rightfully so, a lot of people are saying more like 4 hours, and that's probably true. He's probably been waiting for a lot longer than 40 minutes, to be honest. Probably 40 minutes once he's in the room to even see anybody. But there are a lot of people who are asking very smart questions here, which is a question I don't think we asked, which is about allergies.
Ah, that's a great point. So let's ask about allergies then. Any allergies? Nope, no allergies to anything that I know of. Okay, is the coast clear to move forward? I think we can try to give the morphine.
I think so.
All right, the morphine, let's perform it. Excellent, okay. So now we've given a dose of morphine. The patient doesn't appear to be wincing as much, but earlier we said that he did vomit too. It looks like we have here, the patient's pain is getting a little better after the treatment. Excellent, well done everybody. But what can we do to address that vomiting from earlier?
So there are people who are saying Zofran, which is a very reasonable drug to give, I think, at this point.
Yeah, let's give
Maybe know
Zofran.
what the generic of Zofran is.
What is the generic of Zofran? Here's 5 guesses. 5 clues.
Yep, we have everybody guessing the correct answer there.
Dancing, Sean. All right, we're gonna give it a go. So we're planning it and we're performing it. When we have the IV access, the patient seems to be feeling better. No more vomiting. Excellent.
All right,
Okay.
you guys have started, started really treating this guy appropriately. Just to recap, we checked the vitals, performed a physical exam, we inserted an IV, we gave morphine, we gave fluid, we gave Zofran. Probably and we're looking at things like his heart rate, which is still high, so he's still, not probably feeling back to normal by any means whatsoever. His respiratory rate has come down some. Other interventions that you guys want to do now, or do you want to go towards getting maybe some investigation going? So we got a lot of people saying blood test, ultrasound, straight cath, lab work, CT scan, white blood cell. We got all kinds of people, and most of these are reasonable things. Somebody said straight cath. Do you guys know what a straight cath is? So for those of you who don't know what a straight cath is actually a catheter that's inserted in a male directly into the penis, so it goes into the bladder to drain the bladder. And it's often a common intervention, and it's not unreasonable in a differential diagnosis for a male who's coming in with lower abdominal pain and a lot of discomfort for them to actually be in what's called acute urinary retention, right? So they can't pee. Why? Typically, it's because their prostate is too big. That's like sort of the most common thing. It's because they have BPH and all of a sudden they're obstructed. I would say in a young guy like this who's 29, that's very, very, very unlikely, although not zero. But if the guy was 79 or 89 and you felt his belly and his belly was sort of distended and you could feel a big bladder, then yeah, that could be a reasonable thing to think about. Oftentimes you'd stick an ultrasound on there to see how much bladder fluid he has before you would do a straight cath.
And
Yeah.
before we get into some of those tests, though, that everyone wants to order, I think those tests might eventually get us the answer. But before we do that, let's try to think of what we're looking for on those blood tests. What are the possible diagnoses that we are considering in this patient who's 29, coming in with belly pain?
Yeah, so we have people saying kidney stones, appendicitis, gallbladder disease, infection, not otherwise specified, I guess, gastroenteritis, gastritis, a parasite. We didn't ask about travel. Maybe he was coming from some a foreign place. That's certainly interesting. Kidney stones. So we have a few different things on our differential here. And medicine is all about like coming up with the differential and then thinking through what tests you're going to order in order to get to the right answer, right? And so this is great. You guys are thinking about a lot of the differentials, and Dr. Katz is absolutely right. Before you order tests, you should really be thinking, hey, what does this person potentially have, right? And because that differential should guide your ordering of the different tests, whether it's lab work or imaging or anything else. Because if you don't have that in mind, you're essentially just shooting in the dark.
Yeah, absolutely. So I heard a couple of things. I'm starting to put them down. I heard gastroenteritis, appendicitis, maybe a urinary tract infection of sorts, maybe cholecystitis or inflammation of the gallbladder. What are some other things that we heard
of? We have somebody saying ulcers, pancreatitis.
Pancreatitis I saw on here. We're going to add that there. We saw ulcers.
Norovirus, which I think probably goes under the acute gastroenteritis category here.
A lot of different viral infections here. There's rotavirus. Yep. Okay.
What else we got? We have diverticulitis. That's an interesting one.
Interesting one. Let's see. I think I saw it here somewhere. Diverticulitis. Okay, so we're getting a pretty broad differential, but I see a lot of people are kind of going towards the gastrointestinal illnesses right now, and that makes sense. His pain's in his abdomen. So we have a pretty wide differential right now, and ultimately we'll use that to make the diagnosis after we get all of our tests back. So what tests should we now start thinking about?
All right, so we have people saying CBC. For those of you guys who are not familiar, CBC is complete blood count. It's a very common test that you run. It gives us a bunch of different values, including the white blood cell count, the hemoglobin, the hematocrit. These are important things to understand if a patient is bleeding, if a patient is infected. So if a patient is infected, their white blood cells oftentimes will elevate. If a patient is bleeding, their hemoglobin and hematocrit might be down. We have other people talking about sodium and potassium levels.
Okay, so where would we find those on the test that we can order? Sodium and potassium can be on a basic chemistry or Chem 7, so I'll add that to the test. What else?
Somebody's talking about urine analysis, which I don't think is an unreasonable idea. That would help us understand a little bit about the urine and if there's infection there.
Yep, so I added that urinalysis. So far we have a basic metabolic panel, we have the complete blood count, and we have a urinalysis. Any other tests to send off before we send them all off together?
There's definitely a few people talking about LFTs.
Okay, liver function test, we can do that. It'll tell us things like the bilirubin level, the liver enzymes like the alkaline phosphatase, the AST and the ALT. And then what's right near it on this list of things that would help us with one particular diagnosis that we put on the differential? Maybe this is a read my mind question.
Yeah, no, you got a bunch of people answering correctly. Lipase.
All right, let's add on a lipase because that'll help indicate if this patient's having pancreatitis or inflammation of that pancreas. So we've added that on. Any other things to add? I'm just trying to think before we send them off. I think that was pretty comprehensive.
That was pretty comprehensive. Some people are saying D-dimer as a possibility. I don't know if I would necessarily add that here, to be honest.
We can hold off on it right now and add it on later if we decide we need it. But let's give these tests a go. Let's perform this and see what the results are showing. And of course, things that are highlighted in red or orange, that those are abnormal, we'd say. So let's start reading down the line here. The lipase is 70, which is not highlighted in red, so it's normal. We see the liver function tests are also normal here. What do we see here on the urinalysis? There's a lot of different things to look at in the urinalysis. Dr. Mehta, what do you sort of look at when you're looking at a UA? Because nothing here is really jumping out at you, right?
It's not, but to be honest, I might throw that question back at the internal medicine doc because I haven't looked at a urinalysis.
Fair enough. We look for things like, is there a urinary tract infection? We look at things like the white blood cell count. We look at things like the nitrates and leukocyte esterase, which would point us in that direction. This patient has 8 white blood cells per HPF, which is a high-powered field, which is how the lab kind of defines how they're seeing things. Maybe a little bit high, not too abnormal, honestly. It doesn't look like there's a urinary tract infection because of the negative nitrates and leukocyte esterase. And overall, nothing too crazy, maybe a little bit of ketones here. And then moving on to the basic metabolic panel, we have the sodium, potassium, chloride, bicarb, creatinine or kidney function, glucose. They're all pretty normal. But now when we get into the complete blood count, that's where things start to look a little different. What are we seeing here in red?
Yeah, so a lot of people are screaming infection because of the white blood cell counts being high.
Fair enough. 18.9. What's a normal white blood cell count? Can anybody tell me in the chat?
Yeah, so you got 7 to 11, 9, 10. That's exactly right.
Technically, 3 to 10 is the good range. And so this patient's white blood cell count is definitely elevated, which raises suspicion for, like everyone was saying, infection or some sort of inflammation maybe going on in the body. Okay, that's our blood work. But there's more than just blood work that we can do as doctors, right? So this patient's in your emergency room. You're the emergency room doctor. What else are you going to order to try to get the diagnosis?
So a lot of people are jumping to imaging, which is reasonable. We have a couple of options for imaging, right? And you guys are talking about a few of them. One is an abdominal X-ray, one is an ultrasound, one is a CT scan. There are others who are also talking about MRIs as well. All of these imaging things can show you different pathologies, and some might be more appropriate than others in different settings. As a former diagnostic radiologist, I can opine about this for a little bit, but basically what I would say is an abdominal X-ray is actually not all that useful in most cases, other than to maybe look for a small bowel obstruction or a perforation where you can see free air. The reality is that most people in most centers have probably moved towards more cross-sectional imaging, more advanced imaging, quicker because you can really just see a whole lot more, right? I've talked about two of the things you can see on abdominal x-ray, maybe a couple others, but the reality is you're kind of looking at just shadows, whereas a CT scan, you can actually look inside the body. Other people have talked about abdominal ultrasound, which is, I think, a very interesting idea as well. The thing about abdominal ultrasound that could be really interesting is that if you have a focus differential, so let's say you think that this patient has gallstones and cholecystitis, then an abdominal ultrasound is a great exam because you can stick that probe right in the right upper quadrant and you can look right at the gallbladder. In fact, it might even be better than a CT. When your differential is more broad, it's a little harder because you have to scan the entire abdomen. It's not unreasonable. And it really sometimes depends on the patient, right? Do you guys think there's a particular type of patient that you might have gotten an ultrasound over a CT in every single time of the day, every single time? Yeah, we got a whole bunch of people that are sort of saying some correct answers, right? Pregnancy. If you're a pregnant patient, you don't want to stick them under the CT scanner because CT has radiation, whereas ultrasound doesn't. So you don't want to expose that fetus to radiation. Others are saying minors or children, which is absolutely correct as well. You try not to expose children to too much radiation in their lifetime, particularly when they're young and developing, et cetera. So those are really good places to potentially use an ultrasound over a CT scan right away.
Fair enough. So in our 29-year-old male who's we're concerned about his abdominal pain, what should we pick then? What is our ultimate final answer for the imaging test we should order?
Yeah, so almost everybody is saying CT at this point, which is correct. There were a couple of questions on metal. CT is not affected by metal, or let me say it this way. Metal is not a contraindication to a CT. A pacemaker is not a contraindication to a CT. Now, metal can actually ruin your picture on a CT scan if you have too much of it in the wrong spot and you need to look. So if you have hip replacements, that can be really hard to see things in the pelvis. But just because you have metal does not mean you can't get a CT scan. You can absolutely get a CT scan. Even a lot of metal and pacemakers are what's called MRI compatible. MRIs are different than CT scans. They don't use radiation, but they take a lot longer to get. It's a much longer exam. You have to sit in that scanner for a half hour to get the pictures you need, whereas a CT scan is about 15 seconds, boom, boom, and you're out.
So let's give it 5 seconds and get it done. Let's perform this CAT scan and see what happens. The CAT scan was completed and we have the image here. I'm going to click on it. It may give away the answer, but before we do that, we're going to have the radiologist explain what you're about to see on this CAT scan.
Yeah, so you're looking at a CAT scan here, right? This is something that is taken around the level of the pelvis, and you can tell that because the white things on here are the hip bones, right? Those are your hip bones. The center white is your sacrum and your spine, and then everything else around there is your body, right? So all the black that's around the outside, that's your fat, right? That's your abdominal fat. All the gray in the next layer, those are your muscles, right? And so you can see, by the way, that he's got rectus sheath muscles. We talk about how everybody has a six-pack underneath. Yeah, everybody does have a six-pack underneath. It's that layer of fat that you got to get through to see it, right? You can see the gluteal muscles in the back there. And so those are all the muscles. And then within one more layer down is all the abdominal organs, right? And so in this case, we're down near the bottom of the pelvis. So actually what we're seeing is we're seeing the two psoas muscles, which are the two round things on either side. We're seeing the aorta and the iliac veins and iliac arteries split both right there where Dr. Katz is pointing. And then all these other loops that you're seeing in the abdomen are typically small or large bowel loops, right? And so these are what you're looking for some kind of pathology there, right? And in this particular case, we actually have an arrow and a measurement on something that's incorrect, and that is the appendix, right? And so you can see this appendix is measuring 17 millimeters. Does anybody have any idea what a normal appendix should measure? Yeah, so we got a bunch of different answers, and it should be 1 centimeter or less. So about 10 millimeters or less should be what it is. This appendix is sort of dilated, it's fluid filled, and it's angry because you can tell there's like a little bit of what's called fat stranding around that area. And so for those who are out there who are correctly guessing, this is very diagnostic of acute appendicitis, right? This person has an appendix that's not yet ruptured, but is super inflamed and has appendicitis.
Yeah, absolutely. So the imaging oftentimes gets us the diagnosis, or at least it makes it very helpful to understand. When you combine it with a lot of the lab work that we're seeing, like the high white blood cell count, the patient coming in with a fast heart rate, these things are all kind of indicative of that with the abdominal pain as well. And my favorite thing as a non-radiologist is when I see those arrows on a report, because it tells me what to look at and what's abnormal. So thank you very much for explaining that. And we have an idea now of what's going on. So what are our next steps? We're thinking this patient here in the emergency room on the stretcher has acute appendicitis. What do we do?
So a lot of people are saying call surgery.
Okay, so let's communicate with the surgery team. Let's consult them and say, hey, the surgeon's finishing in the OR, but based on the CT findings, they recommend sending the patient to the OR for appendectomy. They will meet the patient in the pre-op area. So very nice and efficient in getting things done, moving the patient to the surgery. So before we do that, are there any additional things that we want to do to help the patient out? His heart rate's getting better. His fever, I mean, his temperature is 38 degrees Celsius, a tad high. Overall, it looks like he's feeling better. Let's get things rolling and let's talk to the surgeons. And we did that. And so do we admit the patient to the ICU, the floor, prep for the operating room, or discharge?
Dr. Katz, a lot of the people in the audience are asking a couple of really good questions, I think, first, which is, A, do we tell the patient, which is probably we should do, right? We should always communicate with the patient. And then B, a lot of them are talking about antibiotics.
Ooh, okay. Which antibiotics? Now, that's always a good question, too. And why antibiotics?
So we have Augmentin, we have Vanco, we have ceftriaxone, we have Cipro. So we have a few more. We have a few options. Zosyn. People are out there definitely shadowing their physicians because they know a fair bit of antibiotics here.
All right, so let's get a little bit more interventions going then. We can do medications with antibiotics. We can do, what do we have here? What do we got? Something I've often seen done is ceftriaxone and flagyl. That's one regimen, but there's a lot of different possibilities. We essentially want to make sure we're covering the bugs that can attack the internal organs in the belly. So I'm going to put in those antibiotics so we have them going. Let's perform those. And we've now administered them, which is definitely good. Anything else before those, after those antibiotics, before we go to the operating room, or?
Yeah, we've talked about consenting the patient. I don't know if that's an option in our.
Don't think it's an option right now, but we'll prep for the operating room, and then we'll make a decision about what our diagnosis is based on that. We'll prepare for the operating room and pick then what do we think our final diagnosis is, and everybody
all at once. Appendicitis is
let's do the handoff.
Everybody's doing.
All right. Prep for operating room diagnosis of appendicitis. Are we sure? Hang on or finish? I think let's finish and see how we did.
Let's do it. So what's cool? It's going to give us a grade. 95, not bad at all. Everybody.
Okay, where could we have improved here? Our physical exam, maybe a few more things like a cardiovascular exam, or we did a pretty good job, I'd say. We did a pretty good job. And so we're now done with the first case, and the hospital is busy. It's not just an emergency room. There's a lot of other parts of the hospital. And now there's another case in a different part of the hospital. So we're going to move on to that. But before we do, anyone have any questions or comments about this case?
I think we got that case. Why don't we move on to the next one? So
All
you
right.
guys now have a pretty good idea of the different ways that different things that we could do with the software. And so let's take another case.
All right, we're going to pull up another case here. All right. Okay. So remember, this is going to be in real time. We have to make decisions quickly. We now have an idea of how the software works, and we're going to be making decisions together. So I'm going to be expecting comments coming in during this case. So we have to help out this next patient, who's a 61-year-old male admitted for COPD exacerbation, who reports the acute onset of shortness of breath. And the nurse is saying the 61-year-old originally was improving, but now is experiencing acute onset of shortness of breath. So real quick question, what is COPD? What are we seeing?
So we have people saying chronic obstructive pulmonary disease.
Okay, yeah, so there are two different types. There's chronic bronchitis or emphysema, and it's commonly diagnosed in people who have a long exposure to smoking history in their past, and it is a chronic lung disease. So this is a patient who has that, and that was the reason for admission. So it looks like this patient's been in the hospital, but all of a sudden is having trouble breathing. So let's get started. What do we do?
So we have people asking for vitals.
Let's get the vitals going.
Let's see what we got here. Ooh. So some problems in these vitals right away that maybe are a little bit more acute than the last guy we looked at. And yeah, people are screaming at us. High heart rate, low oxygen, low blood pressure. Ooh, we got a lot of stuff going on at once.
All right.
And
What do we do? What do we do? What do we do?
correct. So what do you guys want to do? So you guys have identified a bunch of the correct vital sign abnormalities really quickly. And so a lot of people are saying, put them on O2, put them on O2, which I
Let's
think is reasonable.
let's stabilize this patient. Let's give oxygen. What kind of oxygen? There's a couple different options. There's nasal cannula, non-rebreather mask, non-invasive positive pressure ventilation, or a bag valve mask. And notably, the oxygen level here is like 83 to 85%. And we talked about the normal being 98, 99, 100%. So how do we help out this patient?
So a lot of people are saying start with the nasal cannula, which if you guys remember is that little tiny thing that goes in your nose. That's what a lot of people are saying. Although there are some people who are saying non-rebreathers or not, or even non-invasive.
So we can try nasal cannula, but I worry if we give the nasal cannula, it might not be enough. This patient seems to really be in distress, and the main issue is that shortness of breath. So maybe we can do the non-rebreather mask. What are our thoughts? And let's give that a go.
Okay with that one, yeah.
All right, now we're putting on the non-rebreather mask, and the oxygen level has now gone up to 100%. Okay, so the oxygenation is taken care of for now. What else do we have to do? Because that blood pressure is scaring me.
So a lot of people are saying IV, and actually just looking at our little patient here, I think he already has an IV in there, which is usually the case if somebody's hospitalized that they'll have an IV.
Excellent. So what can we do though now with that IV?
So there's some thought of beta blockers. Beta blockers are something to lower the heart rate. There's other thoughts of IV medications. Which one?
I worry about beta blockers because with that blood pressure, beta blockers can drop the blood pressure even more, even if by just a little bit. But we need to raise up that blood pressure. So medications we can give through that IV, like we talked about, are fluids again. So we have a bunch of different options, but it sounds like we need to get them a lot of fluids quickly.
Yeah, I think in this case, a beta blocker is probably actually a really bad idea. Even though it might treat the heart rate, it would drop his blood pressure even more, and his blood pressure is super low, right? And so a lot of people are saying saline or LRs, which I think is a reasonable thing to at
Great.
least get started here.
Let's give a liter and see how the blood pressure reacts. So now it's already coming up a little bit. I would like to see it come up even more, but it's not coming up that much. So it didn't work enough. It gave a liter of fluid. And I think we should start to think about other things for this low blood pressure because maybe fluids won't do the trick just by giving them themselves.
So some people are saying epinephrine or levo.
Interesting options. So yeah, there's definitely medications we can give through the IV to get that blood pressure up if fluids themselves don't work. Levo is a commonly used one, or norepinephrine, which can stimulate the peripheral sort of vasculature to contract and get that blood pressure up so the organs can get perfused. Let's give that a try because clearly the fluid didn't work. And I know we only tried 1 liter, but this patient seems to be in a lot of distress. So let's see if we can find that. And in the meantime, what else should we be doing?
So other people are definitely talking about asking the patient and communicating with him, chest X-ray. So I think there's a few different things, and physical exam, which we sort of skipped over up until this point.
So I'm going to do the norepinephrine drip for right now to help out, and then we can get started with maybe the physical exam. So what we can talk to the patient or we can examine the patient. What should we do?
So a lot of people are saying talk first.
Oh, always a good option.
What do we want to ask him? So they're asking about smoking history.
I would say probably yes with the COPD.
Yeah, I would wonder, in sometimes in medicine, right? You gotta make decisions fast, and you have to think about the most important thing to get to. And going into a guy's, let's say, extensive history for a small diagnosis is probably not the best thing in an acute situation, right? We know he has COPD. He's been in the hospital. Whether he was a smoker or not doesn't really matter. He's probably a smoker, but the bottom line is he's got COPD and he's having trouble breathing, right? Like, is asking him how many pack years did you smoke and starting to talk to him about smoking cessation a good idea right now? Probably not. We got to do something else. That might happen much later. Uh, Other people are asking about allergies, pain scale, any confusion. Maybe we should ask him if he's having chest pain.
What are you feeling? Yeah, I can't catch my breath at all, and it's been really hard to breathe since last night. Okay, so now this gives you a little bit of information of when this started and what is going on. What other questions can we ask?
So, some people are asking about any pain.
Any pain? Let's see. I have some discomfort in my chest. Okay. So trouble breathing, pain in the chest, these are things that really cause alarm in us as doctors because these are things that need to get addressed quickly in this patient who seems to be uncomfortable and whose vitals are clearly not that great right now.
Yeah, so when he said some discomfort in the chest, I think a couple of people went and wanted to get an EKG. Are there Before we get an EKG, are there any other questions anybody can think of that we absolutely want to ask? People are talking about current meds and allergies. I mean, one of the other things in an acute situation in the hospital is that you often have that information at your fingertips, right? You know what meds they're on, you know if they have any allergies, the EMR will tell you that. And so it's not unreasonable to ask those questions. But again, like, in these situations where people are in distress, you want to try to get as quickly as possible to the thing to stabilize them and get them to the right spot. So I would probably actually skip some of those questions. We haven't done a physical exam yet, and that's maybe a reasonable thing to do as well while we're here.
Organ system should we prioritize here?
Yeah, so people are saying listen to the lungs and the cardiovascular exam, which I think that's reasonable.
So tachycardic, great on the heart exam, regular rhythm, no murmurs, rubs, or gallops. And then we said the lung exam as well. So the pulmonary exam shows fine expiratory wheezes throughout with central rhonchi, no rails, no retractions. So wheezing, which is concerning, central rhonchi concerning, and tachycardia. Okay, any other exams to perform here?
So people are saying the neuro exam.
Fair enough. Let's do a neuro exam. Patient's awake and alert, speech is clear. Neuro exam seems pretty normal.
Yeah, and neuro exams can be very intricate if you want them to be, or they can be pretty quick depending on what you're looking for, right? Um, there are other exams that maybe we could do. Some people are talking about back and flank and abdominal exam. You
Okay,
know,
the back exam looks okay, and the abdominal exam is fairly okay. But again, we talked about the most important ones to do at the start, which is the cardiovascular and pulmonary exams.
so a lot of people now are chiming, I think, for some investigation, and they're talking about things like EKG.
Okay, I think that's a reasonable next step. The heart rate's really fast, and the patient's having chest pain and trouble breathing. An EKG in that situation is always a great next step. Before I do that, what are we thinking on the EKG? What is it going to tell us, or what do we want to make sure is not going on?
Yeah, so we have people saying MI and STEMI, and so for all you guys out there, a MI stands for myocardial infarction. That's the medical name for a heart attack, right? And so an MI is obviously one of the things that we want to rule out really quickly, or if the patient is having a heart attack, we want to get him treated really quickly. And then there's something called a STEMI, which is a ST elevation myocardial infarction. And that's a special type of heart attack that can be treated has to be treated really quickly through coronary intervention. And so that's why it's sort of super important to know what kind of heart attack it is.
Yeah, absolutely. So let's get that EKG. Let's order this right now. And this EKG is done. Let's see if we have the results to pull up over here. All right, let's see if we can zoom this and make this larger. Do you guys see my screen? Okay. So we have the interpretation, which is read as sinus rhythm with T wave inversions in the inferior and precordial leads. But before just reading an interpretation, we look at it ourselves. What are we seeing on this EKG, or what does an EKG itself show us?
So we have a lot of people talking about bundle branch blocks and V-fibs and heart rhythms. The electrical conduction of the heart. What do we think about that answer, Dr. Katz?
Absolutely. That's a great way to put it. It tells us about the electrical activity and how the heart is conducting that electricity, if there's any blockages, if there's issues with the rate at which the heart is beating, if there's issues with the rhythm itself. Is it regular or irregular? Are there certain lengths of intervals that we look for that might be prolonged or shortened? There's a lot of information that an EKG can tell us, and cardiologists are expert at kind of understanding them, but most doctors have to really know how to look at and interpret an EKG, at least the sort of basic things about it, because it's such a valuable tool that we have.
So a lot of people are saying tachycardia, which is the fast heart rate. We're talking about irregular heartbeats. We're talking about somebody threw out SVT. I don't think this person's an SVT.
All right. Yeah, and it is definitely a fast heart rate here. We can see that in the usual heart rate, like we mentioned, is between 60 and 100, and here it's kind of around 140, like we were talking about. There's a lot of nuances to reading an EKG as well, and I don't even claim to be an expert on it, though I'm board certified in internal medicine. But there's a lot to kind of learn on this, and the main thing to pick up here, or the main thing that's commented on, is these T wave inversions in the inferior and precordial leads. And it's telling us that there's sort of these T waves, which are normally kind of lifted up. Here, they're kind of dipping down like a valley. And that's concerning in some of the leads.
Cool. So we've gotten the EKG, and I think the things that we've really ruled out or that the thing that we most wanted probably to look at on that EKG was, is there something intervenable right now, or is there something that we have to do, right? We talked about that ST elevation MI. That would be a specific elevation in some of those lines, and that would mean rush this person to the cath lab. I don't think we're seeing that in this case. We are seeing some abnormal findings, so we probably want to keep going with trying to investigate a little bit more and seeing what's going on.
Well, I'm going to add on heart attack to the differential diagnosis because it's still there. The EKG most likely rules it out, but let's start thinking about other things that are going on. And we have to be quick with this because this patient's clearly in discomfort, but we wanted to guide our next steps of thinking and decision making of next steps to get, next tests to get, and next steps to take. I'm going to add on heart attack here, but what else should I add on?
So a lot of people are talking about pneumonia. We're talking the other bronchitis, pulmonary edema, pulmonary embolism.
Pulmonary edema, pulmonary embolism, I'll add.
We have a vote for aortic dissection.
Yeah, I'm gonna find these. I'll find these. There's a lot. Pulmonary embolism, we're adding it. We're adding, let's see here, bronchitis, we're adding. Oh, I just saw something interesting. COPD exacerbation, maybe?
Yeah, no, I think definitely we have people screaming for that as well. I had somebody say pericardial tamponade.
Oh, cardiac tamponade, interesting.
It'd be interesting. Does anybody know if you thought cardiac tamponade was in your differential, what physical exam finding would you maybe have found in this patient? Yeah, muffled heart sounds. That's exactly right. So cardiac tamponade is basically your heart is filled with fluid, or the outer lining of your heart is filled with fluid, and it can't beat, and so you're hearing you can't hear that heart rate as well, or sorry, the heartbeat as well as you would because you're listening through it through a layer of fluid. So good.
Yeah, so I really like that broad differential that we have because if we don't think about something that might be going on, how are we supposed to diagnose it and order the right test for it? So it's better to keep that differential broad at first and think of all the possibilities of things that are going on, and then we can start ordering tests. But before we do that, I noticed that he keeps kind of holding his arm or just feeling overall uncomfortable. Is there something we can do to help him out, at least for right now, with the pain or discomfort?
So we had somebody say pericardial synthesis, which would be useful if there's fluid around the heart, but we probably want to verify that before we start sticking needles in people's chests. Other people have talked about morphine and pain medications.
I think that's not a bad idea necessarily. My only concern with morphine, and I kind of want to give it, but I worry that could that make his breathing slower and cause problems with his breathing? Not quite sure. It's kind of, in this type of situation, we want to help, but we also want to be very careful because he's so sick with a heart rate in the 140s and a respiratory rate in the 24, like at 24, which is really fast, where we want to be really, really careful about what we're doing and be very intentional. So I honestly kind of want to just quickly investigate this, to be quite honest with you. What do
Yeah,
you
I think we've stabilized. We haven't fully stabilized him. His heart rate's definitely better. His blood pressure is definitely better than we started. His oxygenation is better. His respiratory rate's a little better. He's still somewhat unstable, but I don't think he's dying at this minute, maybe like he was a few seconds ago. But I don't think, um, you know, trying to treat him and his pain is the right thing to do right now before we know exactly what's going on. I think we have to be closer to knowing what's going on, and I think our differential is still too broad.
There's some bedside tests that we can get, but there's blood work that we can get. There's other imaging that we can get. Let's start in the order of blood work. They're here to draw the blood. It's your choice to ask what blood work to get. What do we want to get in this patient?
All right, so we have CBC as a definite. A lot of people are putting that. We also have Chem7 again. Troponin is something that people are asking for. For those of you guys that don't know, troponin is a test for what? Let's see if people can answer that. Yeah, troponins are cardiac enzymes, and they're a good test for if a patient's having a heart attack. Now, again, that's one of the things that we definitely want to understand in this patient, right?
Absolutely. So we added on the troponin, added on the CBC and the Chem7. What else? Just throw out things to order.
Yeah, people are talking about BNP.
Okay, let's order a BMP, and that'll tell us if there's kind of a buildup of fluid and maybe a heart failure type of picture going on. What else?
There are people also talking about D-dimers.
I think this is a great opportunity to use a D-dimer, which helps us determine clotting and things like that. There's a lot of other tests we can get as well. What do we want to add on?
Yeah, other people are saying ABG. You want to talk about ABGs real quick?
And ABG will tell us the oxygenation and kind of ventilation status, the acid-based level of the blood. It's a great test to get when we're not quite sure about those levels. They're a little painful to poke somebody in the radial artery and do, but it's a lot of valuable information we can get. So I'm going to add it on here.
People are talking about possible lactate levels.
All right, let's add a lactate because if it's high, it'll tell us that the blood pressure was low and there's a lack of perfusion or blood flow to different organs. And we're getting a lot of pretty good levels. And in this situation, with how sick the patient is, oftentimes what we get is called rainbow labs, which is kind of like throw the kitchen sink and get a bunch of blood work that we can then test for different things. So there's really not a lot of wrong answers in this situation. So I kind of want to order them all almost.
Yeah, I think in emergency situations we often, do throw things at the wall, right? You don't want to leave something out and then have to run another test. You kind of want to get things done as fast as possible.
Let's get a bunch of those tests ordered and let's see what the results are. And remember, the things that are highlighted are the concerning things. So here we have, whoa. What are we seeing pop up?
Yeah, so they're coming through, and this is oftentimes actually how they come through, right? Like you'll get the ABG result first, and then the lab will call you back, and they'll tell you this is the the hemoglobin result, and then they'll call you back and say the D-dimer is positive. So this is not unusual where you don't get all the information at once, right? And you may be in the room with a patient and potentially even coding a patient, right? I mean, we haven't quite coded this patient yet, but there are times where there might be 30 people in the room and we're doing all these different interventions and trying to find the answer, and we're getting all these different lab work back in increments, right? It's not always that everything comes back in the same instant because things take different amounts of times to run down the lab. But we're seeing the lactate is up, and Dr. Katz talked a little bit about elevated lactate often means that the organs were underperfused for some amount of time, right? And that's probably true, right? Remember, this guy's blood pressure started at 70s over 30s, which means his organs were not perfusing and getting the blood that they needed at that time. I'll let Dr. Katz talk about the ABG.
Yeah, absolutely. The ABG shows us that the pH is normal, but at the same time, the PCO2 or the carbon dioxide level in the blood is high. So the patient has more carbon dioxide in the blood that they can't breathe out fast enough. So it's building up. And then there's also oxygen level, PO2, that's 70, and a normal is 80 to 100. So that level's even low. And we can compare that to the oxygen level on the monitor, which on the monitor is showing that it's better, but we're giving that oxygen through that face mask, through that non-rebreather. And then there's one super high number right here, that's the D dimer. What's the D dimer? What does that tell us?
Anybody know what the D dimer tells us? Yeah, so a lot of people are talking about clotting.
Absolutely. That's a very high D dimer level, and it starts to make us think, is there some sort of clot in the body that's coagulating somewhere that's causing a major problem? And I'd venture to say that's really concerning. And another really concerning number here is the 3,500 of a BNP, which is very high as well. What does the BNP tell us?
So let's see if people are talking about CHF, heart failure.
Yeah,
Yeah, heart failure.
absolutely. And then there's also the troponin, which is 0.4 when a normal is 0 to 0.1 in this lab. So the troponin is also high, so the heart is getting some sort of damage as well. And then the other blood work isn't too abnormal, just the bicarbonate, which is another kind of way to measure the CO2 level, is a little high. So in that case, we have a lot of blood work, but we really got to help this guy out now. We're starting to think in a very particular direction, and there's one best test that I'm thinking about that we definitely need to order for this patient. And I'm wondering if you guys could identify what that imaging test could be.
So a lot of people are talking about echo. So let's talk about echoes for a quick second because it's maybe not unreasonable.
Yeah. Okay, well, to be fair, I think maybe a bedside echo is not a bad thing to do, where we can grab an ultrasound probe, and there's POCUS or point of care ultrasound, where oftentimes you can grab an ultrasound probe that's available, put it on the patient's chest or lungs, and evaluate quickly. And you can see, if you're looking at the heart, you can see how it's squeezing and that type of thing. So honestly, an echo is a really good idea. It's not what I was thinking of, actually, but let's get that bedside echo going. So it's an ultrasound cardiac. And remember, we're doing these things fast. We're moving, we're thinking through, because this patient's clearly uncomfortable and he's not doing so hot. So the ultrasound shows no pericardial effusion. The ejection fraction appears decreased due to underfilling of the left ventricle. There's right ventricular dilation, so the right part of the heart is bigger, and there's septal bowing with a decreased contractility of that right side of the heart, sparing the apex of the heart. Dr. Mehta, what do you think about all of that? That's a lot of words there.
So there is, but there's a couple of things that I think are that we should focus in on, right? One, there's no pericardial effusion. We actually talked about cardiac tamponade as a potential. Without a pericardial effusion, that's not happening. Ejection fraction appears decreased with underfilling. Let's translate that to the heart is not pumping as effectively as we want it to. And there's right ventricular dilation. That means the right side of the heart is actually enlarged compared to what it normally is. And there's a septum in between the right and the left ventricle, and there's what's called bowing of that, meaning that that right side, again, is enlarged and sort of almost pushing up against the left side. And so this is sort of classic of a pathology where you're putting too much strain on your heart. And why are you putting too much strain on your heart in this case? Well, it might be because there's something else going on, and I think we should probably evaluate that a little bit closer with some of the CT scans that people are talking about. I think that is a pretty reasonable thing to look at right now.
Which CT scan? There's a lot of different options here, but there's one that sticks out as the highest yield one. I think the one that's most likely to give us the diagnosis based on everything that we just talked about.
Yeah, so people are talking about CT chest, CT aorta, CT pulmonary embolism. So we have three different options, and going quickly through each of them. So a CT chest, the software here is not necessarily differentiating between contrast or non-contrast, but basically what we want to look for here is we have PE, pulmonary embolism, on our differential, and that ultrasound of the heart that we just saw makes us really worry about that even more, right? Because right ventricular dilation and septal bowing is common for a PE that has what's called right heart strain, so really significant PE. And so what you really want to do is you want to make sure that you give this patient contrast so you can see the vessels. And what radiology can do is they can time the CT at different times to light up the vessels more or less, right? So if you wanted to look at the inferior vena cava, you might do the CT a little later. If you wanted to look at the arterial system, you might do the CT really soon after you give IV contrast, because you give IV contrast, it goes through your vein, it goes in your heart, and boom, now you're injecting it through the arterial system, right? If you want to do a pulmonary embolism CT, well, you got to time it right, because if you think about when the pulmonary arteries are lit up most, it's after it goes through and comes back and then goes through, right? So you have to, depending on what you're looking for, you might time these CTs differently. And so I think in this case, if PE is higher on a differential, which I think we agree it is, it may be a reasonable thing to look at.
Absolutely. Let's give it a go. This is an emergency situation, and we should really make sure we're ruling out the most dangerous thing, and that would be a PE here. And let's see what the result shows. What do we see here?
All right, so what you're looking at here, right, is the chest. So everything in black is the lungs, right? So those are air-filled, those show up as black in this particular window. The big circle you see right in the middle of your screen on top, that's the aorta. And the aorta goes arch, and so it goes all the way around. So it goes up and then around, that's the descending aorta. So it goes up and around like that, the ascending aorta to the descending aorta. And then in the middle there is your pulmonary artery, right? And that's the thing that's bifurcating right there into two different branches, right? And what you see is, you see that that's lit up right now, right? You see all this contrast in there that's showing up bright white. But within that bright white contrast, you actually see areas that are not white. And that's indicative of a clot in that area. And so this is what's called a pulmonary embolism. And people are talking about a saddle PE, and that's exactly what this is. So the saddle PE is basically something that, think of a horse's saddle, and you're sort of overlying both sides. You're going to the right and left pulmonary artery. And so this is a saddle PE, and it's, it is that, period, end of story. There's like no other differential on this right now. And so we got to think about what to do next.
What do we do for a saddle PE? This patient, we have a diagnosis we need to treat. What medication can we give right now that can help with this if there's a clot?
Yeah, so people are talking about blood thinners and anticoagulants like heparin.
Okay, so what is heparin going to do here? Heparin, we can give it as a medication to thin the blood out, to try to break up that clot, or at least prevent it from getting worse, because this patient's shortness of breath and chest pain and all these abnormal vitals are probably because of this blockage. So let's order that right now. And now that we've given this medication, what else do we have to do? This patient's on a general medical floor, and a lot of attention has been drawn to him, but there's other patients in the hospital that everyone needs to take care of. Where can this person go? Where can this patient be moved where he can get more specific care and people can focus more on his situation?
Yeah, so people are talking about the ICU, which
absolutely,
and
it's definitely the next place to go. But there's also specific doctors in the hospital who can really do a lot for saddle PEs to try to help just beyond medication. Who should we communicate with as well in this whole process about more therapy for him?
Yeah, so there's a few different people that people are pointing out, including cardiology, vascular surgery, interventional radiology.
Okay. So vascular surgery says, thank you for calling. I agree with proceeding with systemic thrombolysis. So we gave the heparin. I will evaluate the patient in the ICU and coordinate with our interventional radiology team in case catheter-directed thrombolysis or mechanical thrombectomy is needed. Wow. Okay, so let's do the handoff then. What do? We talked about transferring to the ICU. And what's our final item on the differential diagnosis? We saw it on the CAT scan. It was pretty significant. We all talked about it. What is it?
Everybody's got acute pulmonary embolism in there.
All right, let's put it as the handoff. Transfer to the ICU. Anything else we need to do first, or do we think we're set? We have an idea. I think we continue on. All right, let's see how we did. All right, B+.
Not bad.
All right.
Yeah. But I think we would save this guy's life if we sent him to IR.
Absolutely. Okay, I'm gonna come out of my screen share here.
So that was fantastic, Dr. Katz. Thank you for taking us through those two cases there. I hope you guys learned something. So just really quickly on that last case to wrap it up, we heparinized that patient, and hopefully that will break up a lot of the clot. There are times when actually cardiology or interventional radiology, and this is a case that I do a lot, so I'm sort of excited to talk about it, will go in and actually take out that clot. And so we can actually get into the lungs, into the pulmonary artery from the groin and actually suck out that clot or put medication directly into it to break it up. And you see this really great change in a patient's vital signs almost immediately in some of those cases. Um,
And we definitely would have told the patient we were just in a rush to save his life.
Correct. Yeah, communicate with the patient for sure would be a very reasonable thing to do, obviously, at all times. Well, so listen, guys, I think that was really great. I hope you guys learned a whole lot about medicine. I think the full code simulation is what we used for the software. You guys should check it out. It's really, really cool. You get to click around and do what we just did. I also want to remind you guys, obviously, that Med School Coach put on this event for you guys. And Med School Coach is a company that I founded, and we work with pre-med students in high school as well as college through MCAT preparation, through college admissions, through getting into med school. We've done this for years and years. And, if you're interested in any of those things, tutoring for the MCAT, getting into the right BSMD or college program, or getting into medical school and having our help through those. We've been doing this for 20 years. I encourage you to visit our website or just scan this QR code to get onto a meeting with one of our team members to talk to you a little bit more about how we can help. We also have a lot of free resources that are really cool. So I would check us out at medschoolcoach.com for that. If for your high school students, we're going to send out a quick email after this too. For those of you specifically in high school, we have a partner with a great organization called the High School Alliance for Future Physicians, which puts on events like this. And in fact, the High School Alliance for Future Physicians is putting on an event again with Full Code Medical in a couple of weeks to go through some more case-based simulations. So that could be really cool for all of you guys out there as well. Mike, did you want to say a couple last things about the software, which was really awesome? This was great. I think a great use of it.
Yeah, thanks so much, Sahil. It was a ton of fun watching you guys. Great job on the cases. For anybody that didn't catch the name, the software is Full Code Medical Simulation. And we were watching the browser version of it today, but just want to make it clear that it's really designed for iPhone and Android. So you can find it on the App Store and the Google Play Store, and you can play over 200 simulations just like this in about 10 minutes in between classes or whenever you'd like. And the goal is really to give you the opportunity to practice frequently. The cases are designed for a little bit more advanced students. We're aiming at fourth-year med students and early residency. So there should be plenty of challenge for you. But I get the sense from tonight that a lot of you guys are pretty advanced and might do well on a lot of our simulations. So we do have a special discount code for tonight if you'd like to subscribe to the product, which again, you can find on the app stores under Full Code. You can find it on our website at fullcodemedical.com. And the discount code for tonight is Med School Coach, all one word. And if you use your browser to check out, that's 30% off our Pro subscription, which is normally $72 a year. So that's good for about a month. And tell your friends if you'd like about that code. And I'd love to do more of these, Sahil. It's a great collaboration, I think. And you guys, again, thanks for letting me join and great job.
Yeah. And by the way, all you guys that are out there, I am super impressed. I don't think I would have known 99% of what you guys were chatting in the chat. You guys had amazing differentials. You had really good ideas on what to do next, which is really awesome. So congratulations for all you super smart people out there. You guys are all going to make great doctors one day. Here at Med School Coach, we hope to help you get there. And so we'd love for you to check us out, subscribe to us. We have more events like this coming up. In fact, we have an entire day of what's called the pre-med experience coming up, which is going to include sessions such as this, sessions with our MCAT experts, sessions with med schools. And so you guys will get an email for that very shortly as well. So make sure to check your inbox for those. So this was great. Dr. Katz, thank you so much for leading us through and lending your brain on this.
Absolutely. So this is a great session of Are You Smarter Than a Doctor? And I'd venture to say a lot of you are. You guys did awesome, and you guys are going to all make fantastic physicians. Thanks so much for being here, and we look forward to seeing you at all the future events as well.
All right. Thank you, everybody. Everybody have a great night, and check us out. See ya.